Before we formally open this event, we would like to put down some reminders. This presentation is being recorded. During the duration of this webinar, kindly turn off your camera and keep your microphones on mute. For questions and clarifications, please type your concerns in the chat box. Our moderator will go through the questions during the open forum. Also, please remember to fill out the evaluation forms before leaving the webinar. A link will be provided in the chat box later. In this breakout session, let us discuss the latest updates on the management of chronic kidney disease. This session will be presented by Dr. Juan Miguel Ortiz. He is a fellow of the Philippine College of Physicians and the Philippine Society of Nephrology. He is an active consultant in the University of Santo Tomas Hospital and a member of the Committee on Research of the Philippine Society of Nephrology and the International Society of Nephrology. This session will be moderated by Dr. Micah D.
Good day. I would like to thank the organizing committee for having me as one of the speakers in this very first Tiger Convention. These are the objectives of this session. Let us start with a case that we're presented with. A 41-year-old male was brought to the emergency room presenting with the following symptoms of 3 months duration. Here was the physical examination upon arrival. And the salient features of the patient. Initial laboratory examinations revealed anemia, azotemia, electrolyte abnormalities, hyperphosphatemia and hypocalcemia, proteinuria with CAS on urinalysis with a daily protein excretion exceeding 3 grams per day. He was found to have normal-sized kidneys, both with increased echogenicities on ultrasound. Every year, the renal community celebrates World Kidney Day, focusing on a theme that will bring to fore kidney health in the world's eye. Last year's theme focused on prevention and detection of kidney disease. While the highlight is on preventive interventions, among the objectives was a renewed focus on primary care and education. It is but fitting that this conference may serve as a venue in our re-education about the disease that is steadily growing despite medical field's vast advancements so far. CKD is said to have now afflicted about 850 million people worldwide today. That means 1 in every 10 individuals is suffering from CKD of various stages. And by the year 2040, it is predicted to land fifth as the leading cause of mortality. Indeed, the cost of this disease is high, much more now that we are still in the midst of a global pandemic. The disease encompasses all degrees of decreased kidney function, from damaged at-risk kidneys to severe chronic kidney failure. The US NKF KDOQI proposed a guideline with definition of chronic kidney disease in 2002 to allow clinical translation of epidemiologic research. This was adopted by the KDIGO in 2005 and later updated it in 2012. The definition includes a structural criterion and a functional criterion with a specified duration of 3 months, by which time the irreversible sclerosis would set in, leading to progressive decline in GFR. The staging involves one based on the glomerular filtration rate, thus the letter G used. Some literature even proposed G0, in which an individual will just have the background risk like diabetes, hypertension, without actual renal disease or damage. The other staging is based on the presence and amount of proteinuria. It is of note that by itself, G1 and G2 is not sufficient to define CKD because the GFR may in fact be normal or borderline normal. In such cases, there must be the presence of one or more of the biomarkers of kidney damage like albuminuria, persistent urinary abnormalities, Electrolyte and other abnormalities due to tubular disorders, histologic abnormalities, structural abnormalities detected by imaging, and history of kidney transplantation. The NKF advised that the GFR and the albuminuria levels be used together rather than separately to improve prognostic accuracy in the assessment of CKD. This is utilized to evaluate the risk for overall mortality, cardiovascular disease, and end-stage renal disease, acute kidney injury, and the progression of CKD. Apart from determining the possible cause of chronic kidney disease, whether from a systemic ailment like the presence of diabetes or lupus, or from a primary renal disease like the various primary glomerulonephritis, diagnostics principally directed towards the evaluation of CKD per se typically include CBC, where normochronic normocytic anemia is commonly seen. Other underlying causes of anemia should be ruled out, obviously. The BUN and creatinine are elevated in CKD. Hyperkalemia and low bicarbonate levels may also be seen. Hypoalbuminemia as a result of urinary protein loss or malnutrition is also seen in some cases. Lipid profile should be performed in all patients with CKD because of the risk of cardiovascular disease. Serum phosphate, 25-hydroxyvitamin D, alkaline phosphatase, and intact PTH may also be requested to look for evidence of renal bone disease. According to the NKF-KDOQI guidelines, adults who are not at increased risk for CKD can be screened by dipstick. If the result is 1+ or greater, patients should undergo testing for confirmation of proteinuria, which may be a 24-hour collection or just a spot protein-urea ratio. First void urine instead of a random specimen is recommended so that orthostatic proteinuria can be excluded. Protein-urea above 200 mg per milligram creatinine should undergo full evaluation, and levels greater than 300 to 350 mg per milligram creatinine is within nephrotic range. For patients at risk for CKD, KDOQI recommends using albumin-specific dipstick because albuminuria is a more sensitive marker than total protein for CKD from diabetes, hypertension, and glomerular disease. A positive dipstick should be followed by calculation of your albumin-creatinine ratio, with ratio more than 30 mg per milligram creatinine being followed by full evaluation. For monitoring of adults with CKD, serial measurements of protein-urea ratio and albumin-creatinine ratio are recommended. However, if the albumin-creatinine ratio is already high, total protein-urea ratio may suffice. Estimation of creatinine clearance can be derived utilizing the various formulas available. While the cup of gold formula still remains as a routine, simple means to provide reliable approximation of residual renal function in patients with CKD, our smartphones now allow us to utilize complex and apparently more accurate calculations of MDRD and CKD epi equations. For the elderly CKD, it is important to utilize equations with age as a variable for the appropriate and significant adjustments it bears on the estimated result. Measurement of serum cystatin C levels is gaining greater role in the estimation of kidney function. Cystatin C is a small protein expressed in all nucleated cells produced at constant rate and freely filtered by the glomerulus. It is not secreted but is instead reabsorbed by the tubular epithelial cells and catabolized, so it does not return to the bloodstream. This makes it a valuable endogenous marker of renal function. It has been shown that cystatin-based GFR equations outperform creatinine-based formulas in the obese CKD patients, especially those with BMIs of more than 35 kg per meter squared. Renal ultrasonography is useful for screening for hydronephrosis, which may not be observed in early obstruction, or involvement of the retroperitoneum with fibrosis, tumor, or diffuse adenopathy. Small echogenic kidneys are observed in advanced renal failure. In contrast, kidneys usually are normal in size in advanced diabetic nephropathy, in which affected kidneys are initially enlarged from hyperfiltration. Structural abnormalities, such as those indicative of polycystic kidneys, also may be observed on ultrasonograms. A retrograde pyelogram may be indicated if a high index of suspicion for obstruction exists despite a negative finding on renal ultrasound. IVP is not commonly performed nowadays because of the potential for renal toxicity from intravenous contrast. Plain abdominal radiography is particularly useful to look for radioopaque stones or nephrocalcinosis. Computed tomography or CT scanning can better define renal masses and cysts usually noted on ultrasonography. Also, CT scanning is the most sensitive test for identifying renal stones. Intravenous contrast enhanced CT scan should be avoided in patients with renal impairment to avoid acute kidney injury. This risk significantly increases in patients with moderate to severe CKD. MRI or magnetic resonance imaging is very useful in patients who would otherwise undergo a CT scan but who cannot receive IV contrast. Renal radionuclide scans can be used to screen for renal artery stenosis when performed with captopril administration. It also quantitates differential renal contribution to total glomerular filtration rate or GFR. However, radionuclide scans are unreliable in patients with a GFR of less than 30 cc per minute per 1.73 meters squared. When renal impairment or proteinuria approaching nephrotic range are present and the diagnosis is unclear, after an appropriate workup, renal biopsy may be resorted to. It is also indicated to guide management in already diagnosed conditions like lupus, in which prognosis is dependent on the degree of kidney involvement. This, however, is not done when renal ultrasound already reveals small echogenic kidneys for obvious reasons. Early diagnosis and treatment of the underlying cause and or the institution of secondary preventive measures are imperative in patients with CKD. These steps may delay or possibly halt progression of the disease. Early referral to a nephrologist is of extreme importance. The medical care of patients with CKD should focus on the following. The Canadian Society of Nephrology released guidelines that recommend delaying dialysis in CKD patients without symptoms until their estimated GFR drops to 6 cc per minute, or until the first onset of a clinical indication, which includes uremia, fluid overload, and refractory hyperkalemia and acidemia. To ensure prompt recognition of that threshold, close monitoring should begin with eGFRs reaching 15 cc per minute. Measures indicated to delay or halt the progression of CKD are as follows. Here are the other measures that may delay progression of CKD. A prospective cohort study indicated that in patients with advanced CKD and stable hypertension, antihypertensive treatment with ACE inhibitors or ARBs reduces the likelihood of long-term dialysis and lowers the mortality risk as well. This study involved more than 28,000 pre-dialysis patients with advanced CKD and hypertension with anemia. Based on a median follow-up period of 7 months, the investigators found that in those patients who were treated with ACE inhibitors or ARBs, the need for long-term dialysis was 6% lower than in patients who were not treated with these drugs, with the composite outcome of long-term dialysis or death also being 6% lower. The rate of hyperkalemia-associated hospitalizations was higher in ACE inhibitors and ARB patients, but no significant increase was found in hyperkalemia-related pre-dialysis mortality. Treatment with SGLT2 inhibitors may improve kidney outcomes, especially in patients with diabetic kidney disease. The CREDENCE trial, a double-blinded randomized control trial study of the addition of canagliflozin to RAS blockade in more than 4,000 patients with type 2 diabetes and CKD, was stopped early when an interim analysis showed a significantly lower risk of kidney failure and cardiovascular events in the canagliflozin group than the placebo group at a median follow-up of 2.6 years. The relative risk of end-stage kidney disease, a doubling of the creatinine level, or death from renal causes was 34% lower. The SGLT2 inhibitor dapagliflozin may help prevent and reduce progression of kidney diseases in patients with type 2 diabetes and has been shown to reduce progression of CKD in patients with or without diabetes. In the Fidelio DKD trial of finerenone, an agent from a new class of selective nonsteroidal mineralocorticoid receptor antagonists. Significant reductions in advanced renal and cardiovascular outcomes were seen in patients with type 2 diabetes and CKD. After a median follow-up of 2.6 years, finerenone was associated with a 3.4% absolute reduction in the rate of kidney failure, renal death, and a drop in estimated GFR of at least 40% from the baseline. Those results suggest that there's a possibility of triple therapy with RAS inhibitors, an SGLT2 inhibitor, and finerenone for diabetic kidney disease. Aggressive blood pressure control can help to delay decline in renal function in patients with CKD. The National Kidney Foundation's KDOQI suggests a target blood pressure of less than 130 over 80 millimeters mercury. Systolic blood pressure seems to be more important than diastolic blood pressure. However, systolic blood pressure is also more difficult to control in the elderly patients with CKD. Use of ACE inhibitors or ARBs is recommended as tolerated, with close monitoring for renal deterioration and hyperkalemia. With every dose change, serum creatinine level needs to be monitored. If the serum creatinine level increases more than 30% from the baseline after adding RAS blockers should be stopped. Avoid these agents in patients with very advanced renal failure, bilateral renal artery stenosis, or renal artery stenosis in a solitary kidney. Data support the use of ACE inhibitors and ARBs in diabetic kidney disease with or without proteinuria. However, in non-diabetic kidney disease, these agents are effective in retarding the progression of disease among patients with proteinuria of more than 500 milligrams per day. In the MDRD study, dietary protein restriction of about 0.58 gram per kilogram versus the usual protein diet of 1.3 gram per kilogram per day did not significantly affect the mean change in GFR over 3 years. Secondary analysis, however, suggested that a low protein diet may slow the GFR decline in patients with the most rapidly declining GFR and reduce proteinuria. A meta-analysis by Kasiske et al. Suggested that dietary protein restriction retards the rate of renal function decline, but the magnitude of the effect is relatively weak. NKF guidelines advise that if a patient is started on protein restriction, the physician needs to closely monitor the patient's nutritional status. The link between vitamin D and chronic kidney disease is more known with regards to matters of hyperparathyroidism. However, there seems to be a pleiotropic effect of vitamin D supplementation on proteinuria and progression of CKD. This is thought to be due to the mechanisms relating to the RAS and various signals and pathways. As an example, in a prospective controlled study, daily vitamin D supplementation decreased albuminuria in patients with stage 3 to 4 CKD who had low vitamin D levels and high parathyroid hormone levels. The study population was composed of 50 CKD patients with hyperparathyroidism who were given 600 plus units of oral cholecalciferol per day, and 65 CKD patients without hyperparathyroidism who acted as controls. At 6 months, cholecalciferol supplementation led to a mean increase in vitamin D levels of 53%. Urinary albumin to creatinine ratio decreased from 284 to 167 milligram per gram without alterations in other factors that could affect proteinuria. Control patients showed no change. The changes in 25-hydroxy vitamin D levels were significantly and inversely associated with those in the urinary albumin to creatinine ratio, supporting a possible antiproteinuric effect of vitamin D receptor activation. A quick note on observed subclinical hypothyroidism seen in CKD. Because of these various renal and cardiac effects of hypothyroidism, it was not surprising to report renal benefit from thyroid hormone replacement therapy in patients with subclinical hypothyroidism, whether from the direct nephrological or secondary cardiovascular functional improvements. Just for example, in a study of 113 patients with CKD stages 2 to 4 with subclinical hypothyroidism, thyroid hormone replacement therapy with L-tyrosine delayed the rate of decline in kidney function to ESRD. On average, before the patients were treated with THRT, their estimated GFR declined by 4.3 cc per minute each year Following treatment, the estimated GFR decline slowed to 1.08 cc per minute each year. Based on the slope of the decline in estimated GFR prior to THRT, linear regression analysis predicted that 53 of the 113, or about 46%, would have reached stage 5 CKD, where they would require dialysis or transplantation within 10 years. However, using the altered slope of the decline of estimated GFR after therapy, um, it was estimated that only 10 patients, or 8.8%, would reach this outcome in 10 years. Thus, THRT delayed reaching stage 5 CKD in 43 of the predicted 53 patients, or 81%. The discussion of chronic kidney disease progression will not be complete without the important topic of nephrotoxins that may either further the deterioration or place our patients at risk of serious adverse non-renal consequences. Unfortunately, despite the guidelines and dose recommendations, some patients are still being prescribed medications that are unsafe for their level of GFR. A cross-sectional study that included 373 adult patients with stage 3 and 4 CKD found that about 46% of them were prescribed at least one relatively contraindicated drug, like acarbose or propamide, like uride, nitrofurantoin, or any NSAID, during the 2-year study period. 34% were prescribed NSAIDs. I just hope that this prevalence of nephrotoxic drug prescription is not the same in our local setting. In the same page, smoking cessation has to be encouraged as smokers tend to reach ESRD earlier than non-smokers. This has been demonstrated in an early 2011 Norwegian study, the HUNT-2 study, or HUNT-2 study, that showed that smoking cessation decreased risk for future onset of kidney failure. The following are the features of the uremic syndrome and measures that may be instituted to correct them. For anemia, PSAs, hyperphosphatemias, for hypocalcemia, and for hyperparathyroidism, volume overload, metabolic acidosis. For other uremic manifestations, you may have to institute RRT, and for your cardiovascular complication, treat as appropriate. Besides measures to delay progression of CKD, another aspect of therapy is directed towards treating the pathological consequences of reduced renal function. When the hemoglobin level is below 10, treat with erythropoiesis-stimulating agents, such as epoetin alpha or epoetin beta. Caution should be exercised in patients with malignancy. With erythropoietin treatment, the goal is a hemoglobin level of 10 to 12, as normalization of hemoglobin in patients with stage 4 to 5 has been associated with an increased risk of adverse outcome. Before starting erythropoietin, patients should have their iron stores checked. The aim is to keep iron saturation at 30 to 50% and ferritin at 200 to 500 nanograms per ml. Restricting dietary phosphate is one strategy for correcting hyperphosphatemia. However, because of its complexity and challenges, diet control by itself is insufficient and unreliable for keeping phosphate concentrations within the recommended range. Consequently, the use of phosphate binders like calcium acetate, sevelamer, lanthanum carbonate has been proposed as means of reducing elevated phosphorus levels in patients with CKD. Unfortunately, calculation of the cost-effectiveness of these various agents is complicated. KDIGO guidelines suggest the choice of phosphate-binding agents for treatment of hyperphosphatemia to take into account CKD stage, presence of other components of CKD, mineral and bone disorder, and concomitant therapies and side effect profile. There is no role of primary prevention of hyperphosphatemia. While increased mortality is seen in hyperphosphatemia, hypercalcemia, and hyperparathyroidism, unfortunately, no randomized controlled trials have shown improved mortality in dialysis patients who were treated with phosphate binders, activated vitamin D, or Cinacalcet to manage moderate to severe hyperparathyroidism. There is growing evidence that suggests that correction of metabolic acidosis in patients with CKD may have beneficial effects on protein and bone metabolism. Experts recommend alkaline therapy to maintain the serum bicarbonate concentration above 22 mg per liter. In a study of 134 adults by Ashert with CKD G4 with average serum bicarb of 16 to 20, oral sodium bicarbonate supplementation slowed decline in urea clearance to an average of 1.88 compared with a 5.93 cc per minute decline in the control group. Patients on bicarbonate supplementation were also seen to progress more slowly to ESRD compared to the non-treatment arms of the various studies. Interestingly, no significant report of fluid overload, uncontrolled blood pressure, or other side effects were seen in the treatment arms. A note on the management of cardiovascular risk in CKD is the recommendation of KDIGO for a wider use of statin among patients with CKD. Adults aged 50 or above with an estimated GFR of less than 60 cc per minute who are not being treated with long-term dialysis or kidney transplantation should be treated with statin or a combination of statin and ezetimibe. Treatment with statins or a combination should not be initiated in adults with dialysis-dependent CKD. However, patients already being treated with statin at the time of dialysis should continue. Adults aged 18 to 49 years with CKD G3A to G5 ND or not yet on dialysis should start statins if they have coronary disease, diabetes, prior ischemic stroke, or an estimated 10-year risk of coronary death or non-fatal myocardial infarction exceeding 10%. Adults aged 50 years or older with CKD and an estimated GFR of 60 cc per minute or higher should be treated with a statin. Another point of controversy is anticoagulation. Patients with CKD may require anticoagulation for a variety of indications such as atrial fibrillation, venous thromboembolism, or prevention of dialysis access thrombosis. A systemic review with a meta-analysis of oral anticoagulation in adult patients with CKD concluded that in the early stage CKD, the benefit-risk profile of non-vitamin K oral anticoagulants or NOACs was superior to that of vitamin K antagonists. In the study, which included 45 randomized trials of oral anticoagulant strategies in more than 34,000 patients with either chronic or dialysis-dependent CKD, NOACs provided better prevention of stroke and systemic embolism in CKD patients with atrial fibrillation and early-stage CKD. In CKD with advanced or end-stage disease, however, the authors found insufficient evidence to recommend wide use of these classes of anticoagulants to improve outcome. However, should anticoagulation still be considered, there is low certainty evidence suggesting lower risk of major bleeding with NOACs versus vitamin K antagonists. It is, of course, important that in our managing of G5 CKD patients, we are cognizant of the indications of RRT for proper disposition. These are the indications for RRT. Dialysis preparation should be initiated in an asymptomatic CKD5 ND, not on dialysis patient, at GFR of 8 cc per minute, and that dialysis must be initiated at a GFR of 6. Dialysis should be initiated when GFR is less than 10 if symptoms of uremia or complications such as malnutrition are present, or when GFR is less than 6 in the absence of symptoms or complications. Protein restriction early in CKD as a means to delay decline in GFR is controversial. However, as the patient approaches CKD stage 5, this strategy is recommended in adults to delay onset of uremic symptoms. There is no substantial evidence that low protein intake or very low protein intake, even with keto analogs, significantly delays progression of CKD, even in the largest randomized controlled trial of our MDRT. Of note here is this: patients with CKD who already are predisposed to becoming malnourished are at a higher risk for malnutrition with overly aggressive protein restriction. Malnutrition is a well-established predictor of increased morbidity and mortality in the population with end-stage renal disease, and thus must be avoided if possible. It is recommended to lower salt intake to less than 5 grams per day in adults unless contraindicated, such as those with salt-losing nephropathies, those prone to hypotension and volume contraction who do not have heart failure. It is known that high sodium intake increases blood pressure and proteinuria, induces glomerular hyperfiltration, and blunts the response to RAS blockade, all leading to a more rapid deterioration of kidney function. Not only did the high salt interfere with the antiproteinuric effect of ACE inhibitor therapy in a study by Vector, but it was shown to increase the risk of ESRD independent of blood pressure control. Here are other decisions that as may be applied to a CKD patient as the clinical picture warrants. There is likewise growing evidence of potential health benefits of plant-based diets in patients with CKD, although in mostly observational studies. In individuals with G3, showing a delay in progression to ESRD and dialysis and potential improvement in survival. The KDIGO Clinical Practice Guideline recommends that patients with CKD undertake regular exercise as compatible with cardiovascular health, ideally for at least 30 minutes 5 times per week. However, studies have found that patients with CKD participate in physical activity only 9 days per month, and 45% of patients with ESRD reported not exercising at all. As regards the type of physical exercise for patients on dialysis, the strongest evidence is aerobic exercise, which can improve physical fitness, muscular strength, and quality of life. Resistance training has shown benefit for patients with earlier stages of CKD. Given the limited data available, however, a reasonable approach would be to refer CKD patients to an exercise professional who is qualified to prescribe and supervise an exercise program tailored to the patient's individual situation. Consultations for the management of patients with chronic kidney disease may include early referral to a nephrologist, renal dietitian, surgical referrals, and referral to a renal transplant center. The specifics, of course, are beyond the scope of this session. After that review of CKD, let's go back to the case at hand. You can see that indeed the patient has risk for developing CKD, and we may infer that for now he has CKD owing to the following details. Unfortunately, as in most cases, the element of duration is not available unless the patient had previous laboratory records. Can we assume that the 3 months duration supplied by the case implies the possible duration of uremia, ergo azotemia? Dissecting the various signs and symptoms, we may assign them under particular features of uremic syndrome of chronic kidney disease as follows. As we go through the various listings, it is understood that there will be signs or symptoms that are manifestations of more than one uremic feature and not necessarily exclusive. Now, if you were at the emergency room, what would you do? You ask yourself what finding would be most fatal if not corrected within the hour of seeing the patient. I would say the level of hyperkalemia. Although levels above 6.5 are what is considered as severe hyperkalemia and calls for calcium per IV even without getting an ECG, we know that discussions of the more definitive measure, which is renal replacement treatment with relatives, remember the patient is disoriented, so the closest of kin will have to make the decision, may take some time, especially when they wish to have other relatives in on the decision making. You also have to consider the time element involved as well as the potential consequence of temporary access placement, especially if an intrajugular catheter is contemplated with an unstable myocardium. We have to check our ECG and administer the necessary hyperkalemic regimen, taking into consideration also not to aim for normal levels or lower should the relatives consent for renal replacement treatment, which will drive the potassium levels further down, which is likewise undesirable. Of course, dialysis will not correct all features of the uremic syndrome, and therefore, patients will still need medications. We also have to monitor the blood sugar in order to decide whether he will still need hypoglycemic agents, being cognizant of the worst outcome with lower HbA1c levels and the phenomenon of burnout diabetes. We also have to monitor its blood pressure trends if this will eventually elevate further with correction of the acidosis and thus unmasking its cardiovascular consequence. I believe this is my last slide. Thank you.
In this next lecture, let us discuss the approach and concepts of treatment of the different electrolyte imbalances. This session will be given by Dr. Dexter Clifton Pe. He is an active nephrologist currently affiliated in the University of Santo Tomas Hospital, Cardinal Santos Medical Center, and Clinica Manila. He is also the current faculty secretary of the University of Santo Tomas Faculty of Medicine and Surgery. This session will be moderated by Dr. Micah D.
Good afternoon, everyone. Today we're going to discuss about the electrolyte imbalances that we commonly see in the clinic. And I've entitled this talk as Seal the Spill. For this lecture, I have nothing to disclose except that I am currently employed by the University of Santo Tomas Faculty of Medicine and Surgery as its faculty secretary. Now let's start off with a case of a 28-year-old male who traveled from Samar, who came in because of generalized weakness. 7 days prior to consult, he started to have vague, crampy abdominal pain that later on developed into 10 episodes of watery diarrhea accompanied by anorexia. This has been persistent for 3 days until he experienced generalized body weakness. On the day of presentation at the emergency room, he was stretcher-borne with stable vital signs. He was clinically dry with cardiac, pulmonary, and neurologic findings unremarkable, hyperreactive bowel sounds, and non-tender abdomen on abdominal examination. These are the laboratory examinations that were done at the emergency room. So the objectives for this talk would be to give you a quick overview of the normal values of the different laboratory examinations, discuss the different clinical manifestations of the common electrolyte imbalances that we see, discuss other diagnostic workups necessary for patients with electrolyte imbalances, and discuss about the principles in the management of the different electrolyte imbalances. Looking at the blood chemistry results of the patient, we can clearly see that the patient's sodium level is at 129, so this is below normal values. The potassium is also below normal at 3.07. The magnesium and the chloride levels are within normal. The bicarbonate level is slightly low at 21. So we can roughly say that the patient has some form of metabolic acidosis. In cases wherein there is metabolic acidosis, it becomes important to compute for the anion gap. The formula for the anion gap is the level of sodium minus the sum of the measurable anions, which are your chloride and bicarbonate. Measuring your anion gap will tell you most likely what is the cause of the patient's metabolic acidosis. So applying the formula, the computed anion gap for this patient is 8. So the normal value for the anion gap is 8 to 12. So we can say that the patient has a normal anion gap metabolic acidosis. The creatinine of the patient is at 0.9, which is still within normal. CBC results are likewise normal, except that the neutrophils are slightly elevated and the lymphocytes are slightly below the normal values. The thyroid stimulating hormone, the free T3 level and the free T4 levels are also within normal. So therefore, the patient has a normal thyroid function test. So clearly, based on the patient's presentation and the laboratory examination results that we have, the patient has hyponatremia and hypokalemia. Let's first look into hyponatremia. Hyponatremia is defined as a serum sodium concentration of less than 135 mg per liter. This is generally considered a disorder of water as opposed to a disorder of salt or sodium. This results from increased water retention, and under normal physiologic conditions, our body excretes around 10 liters of water so that we do not develop hyponatremia. There are medical conditions as well as certain medications that can contribute to the risk of hyponatremia. Medical conditions such as surgery or injury, the very young and the very old, renal dysfunction, adrenal insufficiency, hypothyroidism, that is probably the reason why the doctor at the emergency room requested for a thyroid function test, cirrhosis, congestive heart failure, and central nervous system impairment. Medications that may increase risk includes diuretics like your thiazides, indapamide, amiloride, and the loop diuretics, antipsychotic agents like your phenothiazides and haloperidol, tricyclic antidepressants, selective serotonin reuptake inhibitors, pain medications like your opiate derivatives, anti-epileptic agents like carbamazepine and valproic acid, anti-cancer agents like your cyclophosphamide and vincristine, some non-steroidal anti-inflammatory agents, antihypertensive agents like ACE inhibitors and amlodipine, and some proton pump inhibitor may increase the risk for hyponatremia. Hyponatremia is the most common electrolyte disorder that we see in clinical practice. Around 15 to 30% of hospitalized patients will develop some form of hyponatremia. And the prevalence of hyponatremia increases in patients who are admitted due to neurologic conditions, admitted in the intensive care unit and nursing homes, and even among ambulatory elderlies. The level of serum sodium correlates inversely with clinical risk, with levels less than 120 mg per liter being regarded as severe hyponatremia. Mild hyponatremia or serum sodium concentration around 130 to 135 is often asymptomatic or be associated with subtle and non-specific symptoms such as headache, nausea, vomiting, fatigue, confusion, anorexia, and muscle cramps. Serum sodium in the range of 120 to 130 lead to additional non-specific symptoms such as body malaise and unsteadiness. With further acute decline in serum sodium concentration, non-specific symptoms may persist, with overt symptoms becoming more apparent. Rapid declines to serum sodium levels less than 120 mg per liter can provoke restlessness and lethargy. They may progress to seizures, coma, brainstem herniation, respiratory arrest, and even death. Severe hyponatremia is associated with in-hospital mortality of around 25 to 50%, meaning half of the patients admitted with severe hyponatremia may die because of these conditions. Hyponatremia has been associated with increased mortality among the elderly, among patients admitted for heart failure, pneumonia, and in the intensive care units. Even mild hyponatremia independently predicted mortality among patients admitted for cardiac failure and metastatic cancer disease. The vast majority of hyponatremic patients exhibit a chronic form of the disorder. This is arbitrarily defined as hyponatremia developing more than 48 hours in duration. So therefore, we define acute hyponatremia as hyponatremia that occurs or develops within 48 hours. When the time frame of hyponatremia cannot be established with confidence, please remember that it is always safer to conclude that the hypotonic state is that of chronic. Now, looking into symptomatology of acute versus chronic hyponatremia, you can see here that majority of patients who are symptomatic are usually belonging in the acute hyponatremic column, okay? With deaths occurring mainly among patients with severe acute hyponatremia versus among those with chronic hyponatremia. confronted with a patient with hyponatremia, first thing we do is to assess or measure the serum osmolality of the patient. This is done because we want to rule out pseudo-hyponatremic state, like cases of isotonic hyponatremia or cases with hypertonic hyponatremia. Okay? When serum sodium osmolality is normal, we say that the patient has isotonic hyponatremia, and the differentials include hyperproteinemia and hyperlipidemia. Please remember that the sodium decreases by 0.25 mg per liter for every gram per deciliter rise in serum sodium above 8 grams per deciliter, while your serum sodium drops by 1 mg per liter for every 10 millimoles per liter increase in the total lipid concentration. Looking at the hyponatremic states, please remember that the sodium drops by 1.6 mg for each 100 milligram per deciliter increase in your glucose concentration. Okay, so it is imperative to rule out your pseudo-hyponatremic state. So when you have hyponatremia and you have a patient with low serum osmolality, then that is considered your hypotonic hyponatremia. The next step to do is to assess the volume status of the patient. If the volume status of the patient is hypervolemic, these are your differentials: congestive heart failure, liver diseases, nephrotic syndrome, and some advanced renal failure. If the volume status of the patient is considered normal or euvolemic, your differentials may include syndrome of inappropriate antidiuretic hormone, postoperative hyponatremia, hypothyroidism, psychogenic polydipsia, beer potomania. Beer potomania is a syndrome of excessive alcohol intake with a decreased solute intake, idiosyncratic drug reactions from thiazide diuretics and ACE inhibitors, endurance exercise, and adrenocorticotropin deficiency. When you have a hyponatremic hypotonic patient with hypovolemia, you have to measure your urine sodium level. If the urine sodium level is less than 10 mg per liter, then you may conclude that the kidneys are responding appropriately to the hyponatremia. And the probable cause of the hyponatremia is extrarenal, like dehydration, diarrhea, and vomiting. After measuring your urine sodium and it turns out elevated or greater than 20 mg per liter, then you may conclude that the cause of the hyponatremia is probably the kidneys, like use of diuretics, your ACE inhibitors, some nephropathies, mineralocorticoid deficiencies, and cerebral sodium wasting syndrome. So going back to the patient, most likely our patient would belong to the hypotonic hyponatremic state, hypovolemic, and probable cause of the patient's hyponatremia is diarrhea. So confronted with a patient with hypotonic hyponatremia, you first ask yourself, are there presence of severe symptoms? If there are severe symptoms, then you have to address that one. If there's no severe symptoms, assess if there are moderately severe symptoms. If there are presence of moderately severe symptoms, then you have to address the hyponatremia of the patient. Then you ask yourself, are we dealing with acute or chronic hyponatremia? After identifying if it is acute or chronic, you then assess if there is a reduced circulating volume or is there an expanded extracellular fluid, and then you manage accordingly. So how do we manage hyponatremia? Hyponatremia with severe symptoms, whether it is acute or chronic, is given 3% hypertonic saline or your 3% sodium chloride solution, 150 ml for the first 20 minutes. Then you reassess the serum sodium level. So while waiting for the result of the serum sodium level, you may again administer another cycle of 150 ml of 3% sodium chloride solution, okay? Until a target or an increase of 5 millimoles per liter of sodium is achieved. Once you achieve your target or there's an increase of 5 millimoles per liter in the serum sodium level, You stop the infusion of the hypertonic saline. You open the intravenous line by using your plain normal saline solution while looking for the specific cause of the hyponatremia. Once you identify the specific cause of the hyponatremia, you administer the specific treatment if available. And as a general rule, you limit the increase in sodium by 10 millimoles per liter in the first 24 hours, with additional 8 millimoles per liter every 24 hours until you reach a stable sodium levels of around 130 millimoles per liter. And then you check the serum sodium level every 6 hours or once a day once your serum sodium stabilizes. Okay, so that is for hyponatremia, whether acute or chronic, with severe symptoms. For acute hyponatremia without severe symptoms, first thing to do is to stop fluids, medications, or other factors that you know that may contribute to the hyponatremia. You start prompt diagnostic assessment as to the cause of the hyponatremia, and if available, give specific treatment for the cause. If there's an acute decrease in sodium level exceeding 10 millimoles per liter or a sudden drop in the serum sodium level of the patient, then you may give your 150 ml of hypertonic saline for 20 minutes and then reassess the serum sodium level after 4 hours. If you are dealing with chronic hyponatremia without severe symptoms and the patient has an expanded extracellular fluid, the first thing you do is to restrict the fluid to prevent further overloading the patient. You may administer diuretics as the case may be, and we do not usually use vasopressin receptor antagonists unless there are clear indications for its use. For patients with chronic hyponatremia without severe symptoms and the cause of the hyponatremia of the patient is the syndrome of inappropriate antidiuretic hormone with moderate to profound hyponatremia, the first line of treatment is always fluid restriction. If the patient cannot be managed purely by fluid restriction, second line treatment would include increasing solute intake with 0.25 to 0.5 gram per kilogram per day of urea in combination with your loop diuretics and your oral sodium chloride tablets. If the patient has chronic hyponatremia with contracted circulating volume, please remember that the first thing you have to do is to restore extracellular volume by using your isotonic IV fluids like your 0.9% saline solution or plain NSS, or a balanced crystalloid solution at a rate of 0.5 to 1 ml per kilo per hour. If there is hemodynamic instability due to the contracted circulating volume, please remember that the need for rapid fluid resuscitation becomes more important than the risk of an overly rapidly increasing serum sodium level. So we have to restore the extracellular volume first before you address the serum sodium of the patient. So in general, all forms of hyponatremia will respond to fluid restriction. And as you identify the cause of the hyponatremia, you give specific treatment for these causes. For primary polydipsia, so you advise the patient to limit fluid intake. If the cause of the hyponatremia is renal failure, then you might need to do renal replacement therapy in the form of dialysis. If there's true volume depletion, remember, your first line IV fluid will always be an isotonic solution like your normal saline solution. If the cause of the hyponatremia is an effective volume depletion, then identify the cause and treat accordingly. If it is from thyroid hormone or cortisol deficiency, then you have to replace these hormones. If the cause of the hyponatremia is SIADH and the patient is asymptomatic, again, the first line treatment is fluid restriction. Second line treatment would be giving urea or increasing the patient's protein diet, use of diuretics like furosemide, and giving oral sodium chloride tablets. If the case of the patient is caused by SIADH, but with acute mental status change, then you need to infuse hypertonic saline until your sensorium improves. So what is the rate of correction? Remember, for acute or severely symptomatic hyponatremia, we limit our correction to 4 to 6 mg per liter within 4 to 6 hours or until the symptoms resolve. For chronic hyponatremia, the rate of correction will be 6 to 8 mg per liter in the first 24 hours, 12 to 14 mg per liter in the next 48 hours, and 14 to 16 mg per liter in 72 hours. So for chronic cases of hyponatremia, the correction should be very, very slow. So how do we correct hyponatremia? So this is the general formula, okay? Your serum sodium is approximately the amount of sodium in your extracellular compartment or your serum divided by the total body water. So to be able to increase the serum sodium, it's either you add sodium to the numerator or you subtract from the denominator or you limit the fluid entering the patient. There are certain formula that we use when we are correcting the hyponatremia. The first formula is the formula for the sodium deficit. It is computed as 140, which is the desired or the normal sodium level, minus the serum sodium concentration of the patient, multiplied by the total body water of the patient. The total body water of the patient is computed as weight in kilograms times 0.6 or 60% for male and 0.5 for females, okay? But remember, we do not want to acutely or suddenly increase the patient's serum sodium level to 140. So therefore, instead of using 140 minus the patient's serum sodium, what we want to do is to substitute this with our desired sodium. Like for example, if you want to increase the serum sodium level by 8, then we substitute this by 8 times the patient's total body water, okay? That is using the sodium deficit formula. For the Adroge and Madias formula, we make use of the sodium and the potassium concentration of the solution minus the serum sodium level of the patient divided by the total body water of the patient plus 1, okay? But using this formula, remember that the result does not show the amount of sodium to be administered, but rather how much the concentration of the serum sodium will increase after giving that 1 liter of infusate or IV fluid. So therefore, to be able to properly apply this formula in the correction of the hyponatremia of the patient, we have to know that the different IV fluids available for us and the amount of sodium that is contained in each of the IV fluid. For your hypertonic saline solution or the 3% sodium chloride in water, it contains around 513 millimoles of sodium per liter. For your plain NSS or 0.9% sodium chloride in water, it contains around 154 mg or millimoles per liter. For your lactated ringer solution, around 130 millimoles of sodium. For your half normal sodium chloride solution or 0.45% NaCl, it contains around 77 millimoles or mg per liter of sodium. And for your dextrose, 5% dextrose in water, it does not contain any sodium. So applying our sodium deficit formula for our patient, so the normal sodium is 140 minus 129. So the sodium deficit is 11. But remember, we do not want to correct the serum sodium level up to 140. But rather, our desired correction is a maximum of 8. So we use 8 and multiply it to the patient's total body water. So the patient weighs around 70 kilograms. Since he is a male, 60% of the weight is water. So 70 times 0.6 is the total body water divided by 154 mg per liter because I am planning to use plain normal saline solution, because remember, our patient is clinically dry. And as I've mentioned earlier, if there is some form of decreased effective circulating volume, we want to use an isotonic solution. Okay, so 8 times the patient's total body water divided by 154 gives us around 2.18 liters of plain NSS. So I need around 2.18 liters of plain NSS to be able to correct the patient's sodium by 8 mg per liter. Okay, so my plan is to give the 2.8 liters of plain NSS over 24 hours. Okay, now let's move to hypokalemia. Hypokalemia is defined as a plasma concentration of your potassium less than 3.5 millimoles per liter or milliequivalents per liter. And this is associated with a 10-fold increase in in-hospital mortality due to its adverse effect on your cardiac rhythm. The mechanisms why patients develop hypokalemia includes redistribution of potassium between the tissues and the extracellular fluid compartment, non-renal losses of potassium, and renal losses of your potassium. So these are your causes. So very rarely do we see patients with decreased intake causing hypokalemia. Majority of the patient would fall under your redistribution and your increased losses. For the redistribution into cells, examples include insulin excess, beta-2 adrenergic alterations, okay, that causes the activation of your cellular potassium reuptake, like the use of your bronchodilators, your tocolytics, and your ephedrine. Overdose of theophylline and overingestion of caffeine will also lead to some form of hypokalemia. Hyperthyroidism can cause activation of your sodium-potassium ATPase, leading to an increased uptake of your potassium. So these are the common causes of hypokalemia due to redistribution into the cells. For increased losses, non-renal causes of hypokalemia would include sweating under extremes of physical exertion, GI losses, like malabsorption syndromes or diarrhea, celiac diseases, ileostomy, villus adenoma, vipoma, or chronic laxative abuse. Renal causes would include the use of your thiazide diuretics. The use of penicillin may also cause hypokalemia because it increases potassium excretion by acting as a non-adsorbable anion. So antibiotics that are penicillin derivatives may cause some form of hypokalemia. Nephrotoxic agents like your aminoglycosides, amphotericin, cisplatin may cause potassium and magnesium wasting. Aldosterone can activate your epithelial sodium channel, leading to an increased potassium secretion into the urine. Cortisol has similar affinity to your mineralocorticoid receptor, causing also an increased potassium secretion in the renal tubules. Hypokalemia results in hyperpolarization of muscle cells, thus impairing the capacity of the muscle to depolarize and contract, leading to weakness and paralysis. Paralytic effects of hypokalemia on intestinal smooth muscle may cause intestinal ill use. ECG changes are most marked when their serum potassium falls below 2.7 millimoles per liter. ECG findings may give you broad flat T waves, ST depression, or QT prolongation. Hypokalemia can thus be an important precipitant of arrhythmias in patients with additional genetic or acquired causes of your QT prolongation. So this is the algorithm on how we approach patients with hypokalemia. Okay, so confronted with a patient with hypokalemia, very important again to rule out causes of pseudo-hypokalemia. Pseudo-hypokalemia may be caused by laboratory errors due to prolonged standing of the blood before measuring the serum potassium level. Okay, if this is the cause, you might just need to repeat the serum potassium determination and there's no further workup necessary. If you have a patient with hypokalemia, identify if there are emergency causes like or emergency, if this is an emergency, like the presence of paralysis or presence of ECG changes or cardiac arrhythmia, and you have to address that one accordingly. Okay, if there's no emergency need to address hypokalemia, and this is not a case of pseudo-hypokalemia, then you start the investigation of the cause of the hypokalemia. You do your history physical examination. If there are clear evidences of transcellular shifts like excessive use of insulin, excessive use of your beta-2 adrenergic agonist like your salbutamol nebulization, familial hypokalemic periodic paralysis, hyperthyroidism, barium intoxication, excessive use of theophylline or use of chloroquine, then you treat this one accordingly. If in your history taking there is clear evidence of low intake or starvation, then you address the starvation accordingly. Okay? If you have ruled out transcellular shift and if you have ruled out low intake of potassium as a cause of the hypokalemia, then the next thing to do is to request for urine potassium levels. If the urine potassium level is low, okay, then most likely the kidneys are responding appropriately to the hypokalemia. Therefore, you may be dealing with extrarenal causes of your hypokalemia. You might need to do your ABG or acid-base arterial blood gas to determine your acid-base status. If you have metabolic acidoalkalosis, then these are your differentials. If you have a normal acid-base status, probably the hypokalemia is due to profuse sweating. If you have some form of metabolic acidosis, then probably you are dealing with GI potassium losses. So remember, our patient has some or mild metabolic acidosis, normal anion gap metabolic acidosis. So most likely our patient's hypokalemia is due to GI potassium losses. If your urine potassium level is elevated, then most likely you are dealing with renal causes of hypokalemia. And this is the time that you have to refer your patients to your friendly nephrologist. As your nephrologist, what we do is we measure your transtubular potassium gradient. Once we determine the transtubular potassium gradient of the patient, these are the possible etiologies of the hypokalemia that we will be dealing with. Okay, so you just leave this to your friendly nephrologists. So the goals in the treatment of hypokalemia is first to prevent life-threatening or serious complications associated with hypokalemia. Then we replace associated potassium deficits. We will be talking about how to compute for potassium deficits later, and then identify and correct the underlying causes of hypokalemia. Remember that the mainstay treatment for hypokalemia is oral replacement with potassium chloride. So whenever possible, we want to give potassium chloride orally. You want to assess renal function, medications, or other comorbid conditions that may be causing your hypokalemia. Deficits may be replaced gradually over 24 to 48 hours with frequent monitoring of plasma potassium levels. Patients refractory to potassium correction should be evaluated for hypomagnesemia because magnesium deficiency or depletion has inhibitory effects to your sodium potassium ATPase activity. This will result in significant efflux from muscles and secondary losses of your potassium into the urine. So if you have refractory potassium or refractory hypokalemia, you might want to measure the serum magnesium level of the patient. But remember, our patient's magnesium level is within normal. The IV route should be limited to patients who are unable to tolerate oral potassium chloride supplementations or if there are presence of severe complication. This is administered together with saline solution without dextrose. Remember, if you give IV potassium chloride together with dextrose, then it will just lead to a transcellular shift of your potassium into the intracellular compartment. The dose or the dosage is using 20 to 40 millimoles of potassium chloride in 1 liter plain NSS. And the recommended rate of correction would be 10 to 20 millimoles per hour. If you want to give more than 20 millimoles per hour, if there is indication to give more than 20 millimoles per hour, it is wise to use central lines and to admit the patient in the intensive care unit and hook the patient to a cardiac monitor. So how do we calculate for the potassium deficit? The formula for the potassium deficit is your desired potassium level minus the actual potassium level of the patient divided by 0.27 times 100. Why 0.27 and 100? Because in the absence of potassium redistribution, the total body deficit correlates with the serum potassium, such that the serum potassium drops by approximately 0.27 millimoles for every 100 millimole reduction in the total body stores of potassium. Okay, so let us apply that to our patient's potassium level. So 3.5, which is our desired, minus the patient's potassium level, 3.07 divided by 0.27 multiplied by 100. Okay, and that would give us around 159.26 millimoles deficit. So for the patient's 3.07 level of potassium, he has around 159.26 millimoles deficit in total potassium stores. So how do we correct? So this is done by our previous clerk who are now residents. Okay, so at 3.07 potassium level, they gave the patient potassium chloride tablets, 2 tablets immediately, and then 1 tablet 3 times a day for the first day. So please remember that each tablet of potassium chloride contains around 10 millimoles or 10 megs of potassium. So for day 1, they were able to give the patient 50 megs of potassium. For day 2, they continued the potassium chloride tablets, and this time they gave it 4 times a day. So 4 tablets of potassium chloride for day 2 would be around 40 megs of potassium given. On day 3, they repeated the serum potassium level, and it is at 3.36, and it is still below normal. So they continued the 3 tablets of potassium chloride, and this time they started the patient on 2 liters of plain LRS given for 24 hours. Each liter of plain LRS contains around 4 megs of potassium. So for day 3, they were able to give the patient 38 megs of potassium. And on day 4, they continued and decreased the rate of the plain LRS to 1 liter for the day, and the repeat potassium level is at 3.43. So for day 4, they only able to give the patient 4 megs of potassium. So a total of 132 megs of potassium were given to the patient for 4 days. Okay, so applying again the formula. Okay, so our desired potassium level is 3.5. The latest potassium level of the patient is 3.43 divided by 0.27 times 100. So the total deficit for potassium now is at 26 megs per liter. And having added to the patient 132 megs per liter, so all in all, the patient has around 158 megs of potassium. Okay, so that is very, very close to our initially computed 159 megs when the patient's serum sodium potassium level is at 3.07. Okay, so at 3.43 potassium level, we are now short of 26 megs per liter. Okay. So in summary, remember, for hyponatremia, fluid restriction remains the cornerstone of managing oligosymptomatic patients with euvolemic or hypervolemic hyponatremia. Hypertonic saline is required for patients with severe symptomatic hyponatremia, and isotonic saline will correct volume depletion associated with hyponatremia that are euvolemic. Okay. For hypokalemia, remember that oral potassium is still the preferred route of administration for correction. Consider only giving IV potassium chloride solution if the serum sodium is less than 2.5 or there are life-threatening conditions like paralysis or cardiac arrhythmia. And when giving IV potassium, please always remember to monitor the urine output. If the urine output is decreasing or if there is no urine output, be very, very careful in giving your IV potassium replacement. Okay, so special thanks to the consultants and the faculty staff of the Faculty of Medicine and Surgery and USD Hospital, the fellows in training of the Section of Nephrology, USD Hospital, the residents of the Department of Medicine, USD Hospital, and the clinical clerks who gave the presentation in the way how the potassium is corrected. So are there any questions? And I thank you all for listening.
You may now proceed to our Sunset Symposia. Please go to www.tiktok2021.com and click on the room you would like to join.